Dr. Ojur, welcome to the podcast series.
Thank you so much. Thanks for having me, Shane.
You're very welcome. So when we look at some of these cases of falls, let's first start with how serious is falls, in a South African context.
In South African context, I think falls take up quite a bit of the patients that are seen in pediatric trauma sense. Falls for children, especially, is something that's also part of growing up and living. All of us fall trying to walk,
Right.
but it's some falls are more serious than others. With us obviously seeing the more serious ones when the children present to the hospitals. But the important thing is that most of these falls, the serious ones, are at least in some ways preventable.
Right.
Yeah.
So with being cautious and things happen in and around the home, as you said, children will be children, and there may be a need for just that little extra bit of vigilance.
Yeah.
So if we look at the cases, the types of cases that you get to see, the resultant from falls, what do you think are the major causes?
Major causes often children being left unattended to, unsupervised, or children being left situations that allow them to get into dangerous situations, enabling them to fall. So if you leave stuff, for instance, in the backyard that kids can climb onto and jump off of, it's obviously a risk factor for falls. If you allow your kids to play outside on the balcony, huge risk for a fall. Maybe an adult on the balcony by themselves isn't a bad thing, but a child, definitely 2 years old, should not be out on the balcony on the third floor by themselves unattended.
Right.
So the major cause of bad falls often is kids being left unattended, unsupervised, or being left in an environment that's not suitable for them to be left alone by themselves.
So when these cases come into the hospital, and I sometimes joke with some of the other healthcare professionals when I say it's as long as a piece of string, because it can be anywhere, but but those cases can present anywhere from a laceration that requires a bandage or a band-aid to traumatic brain injury, with potentially significant consequences in terms of quality of life in the mid and long term. Walk us a bit through, the range of those types of injuries.
So I'll go through, try and go through it based on ages. So the young kids, basically from about birth to about, call it 3 or 4 years of age, when they fall, usually it's falling from a caregiver's hands or from a bed or from something they crawled up onto. Because they aren't very aware of their body, they often end up getting head injuries because they don't know how to defend themselves, rather to protect themselves. Older child will know to put an arm to prevent or break the fall, for lack of a better word. So the younger kids generally, whether they're falling from a bed, they're left unattended on, rolling off,
the reflex is not there.
Falling from a caregiver, throwing them up into the air for whatever reason does happen, or falling from a piece of furniture, often result in them getting head injuries. Okay, and those head injuries can become quite debilitating for them, depending on the severity, because it's a developing brain.
Right.
Now you've put this insult on this developing brain that's going to impact this child's development going forward. So what may seem like a minor fall in the long term may result in other problems. It may not be immediately obvious, like learning disability, but often with these kids, the parents will report there's been a change in the child's temperament. So he's fighting everyone in preschool. He doesn't want to listen. He's easily angered. Those things that maybe when you can show up on a CT scan, with minor concussion, we think he'll be fine. He'll go home. The moms often come back and report that although there's nothing in the CT scan, he is fine. His temperament, or her temperament rather, has also changed following the head injury. Then we go up a bit older, like I said, above maybe 4 years old, become more aware of your surroundings and you're able to do things to protect yourself. So these kids are often a bit more adventurous, playing outside, doing things a little bit more risky, a bit more independent, climbing trees, hanging from monkey bars and that sort of thing. So when they fall, they often try and break the fall and try and protect what's important, the head and that sort of thing. So they'll throw out an arm. So in these kids in the mid-range, it's often fractures of the arm, especially the upper arm, wrist fractures, clavicle fractures, or rather the collarbone, depending on where and how they fall.
Jungle gym.
The same is carried through from that, like 4 to to 9 age range, and then as the kids get older above 9, it will be the same injuries, sort of the arms, bit of legs, but definitely I think there's definitely a split between very young children and older kids. So very young kids, I would say maybe under the age of about 4 or 5 get injuries. That's not to say the kids above the age of 4 or 5 don't get head injuries, but not maybe as much as young kids, not as severe. Just being my experience.
So I picked that up in the literature too. It's like under 19, is all affected by it. But the first or the most important group is that 0 to 4 that has the highest incidence of falls being, they're the most at risk, if we can put it that way. So when you are dealing with these cases, what treatment do you do? I mean, those broken bones, not all broken bones are put in a cast. And there's other supportive treatment that one can use. But walk us through, like you said, many of those kids pick up some kind of a change.
From the beginning, you'd come into trauma department, you'd be seen by the nurses triage just to gauge how ill are you. Do you need to jump the queue? Are you a red patient or a green patient that can wait a bit longer? Then you see one of the doctors, will take a history, try and figure out what happened. I'll often ask the parent and then ask the child. The child can explain themselves what happened. It's also important to try and get their version of events.
Of course.
Because parents sometimes weren't there, or maybe their version of events aren't the truth. So you get a history, then you do an examination, focusing on what's important, on where the pain is and what's sore, and how they fell. Your examination thing, they're going to guide your investigations. So what are we going to do? An X-ray? Are we going to get a CT scan? And then based on what we find there, we can aim or rather tailor the treatment to what the patient
specific
needs.
Injury was.
And that could be the child has broken an arm, and they require to put into a cast. Maybe requires them to be sedated and us try and pull and straighten the bones. Perhaps they've had a head injury. It requires them to be intubated or to be seen by neurosurgeons or just admitted for neuroobservation. So it all depends on what we find. But we all have the same starting point, but then it's sort of like the different paths
it could take
later become evident. And then once they've been discharged or sent home, there's often a follow-up for, in particular, our head injury patients. If you've been admitted, generally you follow up with our head injury clinic, which is run by the trauma doctors, where I work at least. And then we would ask the mom, how's the child doing? If there's anything that needs to be done in terms of stitches being taken out or that sort of thing. We also get to see an occupational therapist, also screened by a speech therapist. So it's not just on the medical front that you'll be reviewed. It's maybe you didn't see a speech therapist or occupational therapist on your admission, but when you come back for review, they'll definitely just go through with mom or dad the assessments and try and figure out, has there been any lasting effect from the trauma? Yes, because I think it's important that we don't just try and treat the acute injuries, because it's what happens afterwards. That's also quite important.
It's the tail end of the continuous support.
I think in our setting in Africa, South Africa in particular, that's one of the places I think many institutions fail to carry on the treatment, is the follow-up.
That's the follow-up. Now, there are also instances when falls are presented as accidental, but I mean, your medical investigation may find otherwise. So what do doctors look for, and how do doctors make a determination whether an injury, in particular fall, was in actual fact an accident, whether it was negligent, or whether there was an element of child abuse perhaps involved?
This is one of the hardest parts of the job, is the child abuse. And often it was presented as an accident or something else. No one's going to come and tell you that they've used their child. So what we look for is basically the history. Does the history match the injuries? That's one of the most important things. So for instance, if a parent says that the child fell off the dining room table and bumped his head, and now he's not quite himself, he's a bit tired and whatnot, he's vomiting a lot, and we do a CT scan, we find multiple skull fractures, or cracks to his skull. That wouldn't be in keeping with a single event. Or if we were to find in a child that apparently fell from a chair or something, and we x-ray his arm, and there's fractures of differing ages. So we find maybe an acute fracture or acute break in the arm, but there's also older fractures that are showing signs of healing.
Right.
So the main things to look out for: does the history match the injuries?
Right.
Could this be accounted for? And then secondly, injuries of differing ages. And those injuries could be, like I mentioned, fractures. There could be bruising. Maybe you fell today, but a bruise from today looks very different from a bruise that happened last week.
Of course.
And so if you can't account for what happened, that raises huge red flags.
Yeah.
Another thing we look for is the interaction between the parent and the child. So when I ask children what happened, I'll look at how
the parent
how they react, how they relate to the parent. Do they look at the parent for sort of, I don't know, out of confirmation, can I speak, or are they, looking for a cue not to speak, or that sort of thing. So how the child and the parent interact with regards to history. And if I'm asking the child, I don't want the parent to answer. I'm asking the child, often I'll stop and look, I'll ask you just, I want to hear what she has to say, what happened there. So just to summarize, it's, do the injuries match the mechanism of injury? Are there injuries of differing ages that are unaccounted for? And the child's version of events.
Right.
And the interaction between the parent and the child, and just the parent's general demeanor. Do they appear defensive? Are they overly aggressive? And that sort of thing. There's telltale signs that on the job you get to learn. It's quite difficult to try and remain neutral in the situation, because although we are playing the role of sort of as in the case of a child abuse or neglect case, we're playing a role of sort of an investigator. We're not there to try and blame anyone. So our job is not to say that, oh, you did this. Our job is to look at the situation and be like, okay, this has happened, doesn't make sense. We're not accusing anyone of anything, but what you are saying and what's presenting don't add up, and therefore we need to institute further investigations into what might have gone on.
Of course. And I mean, that's also one critical element of the work that ChildSafe does, is when the referrals are sent for the social workers to sort of elaborate or investigate a little bit further for those patients. So in terms of falls, when we talk prevention, I mean, you've mentioned children rolling off the bed. You've mentioned they fall out of a caregiver's arms. What kind of prevention advice and strategies would you recommend to reduce those incidents of falls?
It have to be age specific on the child. So the safe precaution you take for a 10-year-old will be different from a 1-year-old or a 1-month-old. But it's basically look at your environment through the eyes of a child. Where could this child potentially get hurt? And try and modify and maybe limit the risk the child has to exposures, from falling off a chair to rolling off a bed. If, for instance, if a baby above the age of 4 months is able to roll, then you would know that I shouldn't leave my baby unattended on the bed, even if I'm just going to check on the stove, because the child could roll off the bed and fall into the floor. Children that are a bit older should be guided not jumping off furniture or climbing too high into trees and that sort of thing, because they could fall and get seriously hurt. You should always know where your children are, because without knowing where they are, you're not sure what they might be exposed to. And then maybe just in general, just trying to be more aware of what's going on around. In today's day and age, with the whole digital age, we're all very distracted, always on our phones. A lot of kids are on their phones, walking around and falling, tripping over things. They're not focused on what's going on. They're mirroring what the adults and everyone else is doing. We're all just in a world of our own a lot of the time. So, just trying to create situational awareness.
So I think, also the other thing is most people, when an accident occurs, will probably run to the hospital as a first point of call. Can you help us with some observations or guidelines that may help determine between less serious injury that may not necessarily require immediate attention to something that you should get to the ER room immediately?
Just in general terms, you look at the mechanism of injury.
Right.
Okay. Did your child trip over his shoelaces or her shoelaces and fall and bump her head?
Yeah.
Okay. You're very unlikely to get a serious brain injury from falling from a standing height.
Yeah.
As a child. That in comparison to, did the child fall from a 3rd-story balcony?
Okay.
So if a child ever falls from a height, greater than standing height,
Right.
that would be considered a potential for a serious injury resulting from a fall.
Right.
But if you're falling from a standing height, in general terms, you shouldn't sustain any serious injuries, particularly to the head, that would require, imminent, like surgical intervention, that sort of thing. You obviously can fall and break your arm, and that sort of thing. But just in general terms, look at the mechanisms of injury. How did the child fall? What height was involved, and how were they presenting afterwards? So did they fall from standing height and get up and cry a bit and then move on with their lives and get on with it? Or have they fallen and now they're limping and they're not quite moving the way they were 10 minutes ago? Then that would obviously help direct what you should do. So the way the injury happened and how they are afterwards. Has they been vomiting? Have they been confused? Do they have an obvious fracture or break in the arm or leg and that sort of thing?
So, I mean, that's one thing that most people don't actually realize is that you can see an obvious fracture where you can see that this, it's not aligned. And then there are the less obvious ones that you can't necessarily see, but that is indeed there. And I think that's probably the difficult one for parents to determine, should I really, is this just a cry for attention or does it require a doctor's intervention?
Yeah, it is quite tricky, obviously, because we don't have X-ray vision. That's why we use X-ray. So you can often tell if a child is maybe not being entirely honest about the pain. But I think if the parent is concerned, maybe not rushing to a hospital per se. I think, okay, she fell from a standing height and they're complaining of a painful wrist, but it doesn't look broken. It's not swollen. Maybe start at the clinic. Start at the GP, and then should they find anything concerning, they can always refer on, because it's not everyone that falls needs to be seen at a quaternary hospital per se.
Right.
There are levels that can help you
assist.
Appropriately. And in the case of an arm where the child says it's very sore, you can say, okay, she's saying it's sore. Let's try to give her something for the pain. Does it get any better? Give it a few hours. Is she still in pain? Or the next morning she's still in pain? Then often help you direct what needs to happen next. There are a lot of parents that are new to parenting and child falls and appears completely fine, but they will rush immediately. And we can't blame anyone. I mean, everyone's new to parenting when it happens. There's no instructions or parent manual anyone's given.
Sure.
So
that's great. So thank you, Dr. Ojur, for talking to us about falls and fall prevention in our context, and for sharing some of your experience and expertise. If you have enjoyed the content of this video and would like to see more of them, please don't forget to like, follow, share, subscribe, so that others in your network can also benefit from the insights you've gained here. Until next time, take care